Hi, and welcome everyone. Thank you so much for joining us. Sorry for all these pop-up notifications here. My name is Elizabeth Daly, and I'm the Executive Director of the National Foundation of Swallowing Disorders. It is my pleasure to welcome you here this evening for this highly anticipated webinar with Dr. Humbert. We have nearly 2,000 registrants from over 50 countries, which is a new record for our organization. For those of you who might be unfamiliar with the NFOSD, our mission is to advance the treatment of swallowing disorders in our lifetime, and we do this by offering support, providing high-quality free education, promoting promising research, and raising awareness of the impact of swallowing disorders at a local, national, and global level. And while I have a large captive audience here, I would like to share a major advocacy initiative that the Foundation is planning in collaboration with the Think Foundation. We are preparing to host an externally led, patient-focused drug development meeting on dysphagia. This is a powerful opportunity for people living with dysphagia to share the real-life impact of swallowing disorders directly with the FDA, researchers, and industry leaders, helping to drive meaningful change for dysphagia treatment and research at a time when it's needed more than ever. You can find more information by scanning this QR code, and you can also register for our upcoming community webinar about how you can participate in this meeting, which will take place virtually in June. We are still looking for a handful of people living with dysphagia and their loved ones to participate in a speaking role during this meeting. So if you're interested, please feel free to reach out. And I know that June feels far away, but it will be here before you know it. June is National Dysphagia Awareness Month, and we are excited to be hosting an awareness campaign titled Lair in Jeopardy, where each day we will be sharing a dysphagia-related question on our Instagram page. One person who responds correctly and tags a friend will win a prize, either a gift card or a prize provided by one of our industry sponsors. So make sure you follow us on our Instagram, and you can find the QR code for that right here. And as a nonprofit organization, we rely on the generous financial support from our community and industry supporters. We would like to recognize Bracco Diagnostics for their unrestricted educational grant that allows us to continue our TED Talk series. And I would also like to take a minute as well to recognize our educational sponsors. Their long-term support has helped our webinar series grow since its inception almost 10 years ago. And a big thank you to those of you who are paying NFOSD members and those of you who made a donation upon registering for today's webinar. It's important to our mission to offer high quality free education and to make this accessible to everyone regardless of your financial situation. This is the first TED Talk that we have offered for ASHA CEUs, and it does cost our organization to provide these. If every registrant for today's webinar donates $1, we would be able to offer free ASHA CEUs for the remainder of the year. If you would like to contribute and you have the means, we invite you to scan this QR code or visit our donation or website. Every dollar really makes a difference, and we thank you for that. For those of you who have not previously joined our virtual events, please note that you will be muted throughout the whole presentation. We encourage you to ask questions at any point using the question box in the toolbar. We have saved plenty of time at the end to answer your questions. And then for those of you tonight who are interested in receiving ASHA CEUs, please note that these are only available for the live broadcast. Following tonight's webinar, you will receive an email with a survey. It's required that you complete the survey by April 15th in order to receive the credit. For those who complete the survey but don't need or want the ASHA CE credit, there will be a certificate of participation provided. And I do want to thank the Swallowing Training and Education Portal for being our ASHA CEU administrator for this. And now it is my pleasure to introduce Dr. Ianessa Humbert. Dr. Humbert is a renowned scientist, professor, and speaker in the field of swallowing and swallowing disorders. Known for her dynamic and thought-provoking teaching style, she has delivered hundreds of presentations worldwide, challenging clinicians to rethink their approach to swallowing assessment and treatment. Dr. Humbert is the co-creator of the Down the Hatch podcast and the Swallowing Training and Education Portal, often referred to as Swallowing Netflix. She has developed widely used educational tools and videos, many of which you can find on the Foundation's website. With faculty experience at Johns Hopkins, the University of Florida, and the University of Iowa, Dr. Humbert continues to shape the field through education and innovation. So please join me in welcoming her tonight and give us just 1 second here to transition to her slides.
Hi, everybody. So glad that you guys are joining, and I'm just going to pull the slides up and we're going to get going. All right. Okay, so we forgot to get rid of this toolbox over here. Okay, so first, one disclosure that was not mentioned that's really important is that I'm the CEO, founder and owner of Swallowing Wellness. It is the world's first outpatient center for people with swallowing disorders. Right now, it's the only place you can get a swallowing x-ray outside of a hospital. And we are very proud to be patient-centered, which means that we focus on personalized eating plans, which I will explain and show how that is important in one of the myths. We are in downtown Bethesda, Maryland, and we offer everything a hospital has. We have endoscopy, we have video fluoroscopy, and we're just trying to make sure that the outpatient space is filled with a service for patients. So that means that two disclosures, Elizabeth mentioned that I'm the CEO of Swallowing Training Education Portal, but also I'm the CEO of Swallowing Wellness. So when that comes up, I just want you to know that. All right, let's jump right in. So I have a disclaimer. I was born a nerd. This is me as a nerdy 4-year-old. And I was raised in Toronto, Canada. We go to school and starting at age 4, or junior kindergarten is what we call it. And at that time, one of my favorite cartoons was the Smurfs. And so as you can probably imagine, I really identified with Brainy Smurf. And my family really didn't like the way I would always be like, actually, with my little nerdy self. So it's actually perfect that I was asked to do this, because you'll hear a lot of according to so-and-so at all. Because really what I'm going to try to do is I'm going to try to give you guys some of the myths, but I want you to understand that I'm trying my best to back it up, not just with research evidence, with clinical evidence, with patient wishes, as well as with common sense. All right. Now, look. I recognize that you might want to kick me out of the village after this. And trust me, this is not the first time I've almost gotten kicked out the village. But I'm willing to do that if it means that we all become critical thinkers, okay? So here is my list of 6 myths, and they start with this. Myth number 1 is good research evidence supports swallowing therapy. Myth number 2 is diet recommendations should be based on food texture before chewing. Myth 3 is the hyoid bone opens the UES and inverts the epiglottis. Myth 4 is that a diagnosis of aspiration pneumonia means aspiration caused pneumonia. Myth 5 is that SLPs are foremost trained in swallowing. And myth 6 is that patients who aspirate or have significant residue should not eat. So let's start with number 1. Elizabeth has given you guys access. There's a link that you guys should be able to see to a PDF, and it's this PDF, and I want you guys to read it. I don't have time to go through the paper, but I will be referring to it. Principles of experience-dependent neuroplasticity, implications for rehabilitation after brain damage. Jeff Lime and Teresa Jones give us 10 important principles of neuroplasticity. And it's important that I point this out, because I'm going to talk about something that's going to help to burst this myth. And I want to talk about brain-derived neurotrophic factors. You don't have to remember what that is. Just know that BDNF plays a crucial role in neuroplasticity, the brain's ability to reorganize and form new connections after injury. This will come up again. But the reason that it supports this myth is because there's this idea called transference in neuroplasticity. Transference says that plasticity in response to one training experience can enhance acquisition of similar behaviors. Why does this relate to swallowing therapy? Well, because we do things like speech sounds, k and g for base of tongue, pitch glides, maneuvers like Shakir, devices, EMST, lingual strengthening, chin tuck against resistance. Our thought is that if we do a similar or associated task or use those structures in a different way, it will transfer to swallowing. And what I'm saying is that we need good research evidence to support that this kind of swallowing therapy actually transfers, and we don't have it. So here's how I'm going to show that to you. According to many, the best study we have with the highest and most rigorous criteria that is closest to a randomized control trial is a study with the first author, Jerry Logeman, last author is Reza Shakir, and it's about the Shakir maneuver. And so what they did is a lot of things really well. And this is the best we have, guys. So let me walk you through it. They started the study with modified barium swallow study to confirm that the swallowing problem they say they're going to change exists in the population of patients they picked. And after they found that problem, they then randomized them into a control group where they did traditional therapy and an experimental group where they did experimental therapy, which then would be the Shakir, to compare them. They started out with 19 patients that are very heterogeneous in nature. I mean, stroke, head and neck cancer, and they ended up losing quite a number of patients throughout the study, unfortunately, so it was a much smaller number. And then, so, you know, the control group did what it's supposed to do. Shakir group did what it's supposed to do. The Shakir group, they did the Shakir maneuver because that's what the Shakir group does. But the traditional group did supraglottic swallow, Mendelssohn maneuver, tongue-based exercises, which is pulling the tongue straight back and holding it in that position, extreme retracted position for count of 5. They also did yawning and holding the tongue in its backward position for count of 5, pretending to gargle and holding the tongue in the extreme retracted position. You get the point here. This is a very heterogeneous traditional therapy group. Some things we don't actually do, perhaps anymore. Maybe it was something people were doing. And there's also the question that Shakir is supposed to really target UES, but really these don't directly target it. So what the comparison is not quite clear. And then they did the right thing. At the end of this, I think, 6-week period, they then all had them, whoever was left, do MBS to recheck that the swallowing problem you said you can change to see if it changed. And when they did the analysis, they were blinded to study group, meaning the person doing an analysis didn't know if they were in the traditional or Shakir group because there's natural human bias. And here's what they found, that there was greater reduction in post-swallow aspiration in the Shakir group, but no indication about whether it was related to what Shakir is supposed to do, which is target the UES. They found no difference in residue, but unfortunately, the study gave us no connection to physiology. And again, this is one of the better designed studies that we have to show that these non-swallowing tasks impact swallowing. So why is no connection to physiology important to me and should be important to you? The answer is as follows. 1, it's important to confirm that physiology is responsible for bolus flow. They talk about that in the paper, that physiology is important, which is why they did the MBS in the first place. 2, they actually collected MBS studies, which is great, but it had the physiology in it, like it had the reason why people were aspirating, but they then only reported the aspiration and residue. They didn't really connect whether or not the people who had less aspiration were because the UES was working better, which is what it's supposed to target. Let me give you this example of why I'm frustrated. So let's say there's a study that I say I want to do where I claim that more motor vehicle accident fatalities are caused by distracted driving than alcohol use in the East Coast versus the West Coast. Well, you can already think of what I'd have to collect to get that data. I'd have to get the records of mobile phone activity and alcohol levels of drivers involved in fatal car crashes on both the East and West Coast, right? Because those are all the things that tie me to the answer. But what if my result said this? The East Coast has more motor vehicle accident fatalities than the West Coast. That's the answer. You'd still be going, right, but why? Is it because of distracted driving? Is it because of alcohol, right? You don't have that information. So again, most of the studies that are in swallowing therapy do not connect the physiology to the bolus flow. They just say penetration aspiration score changed and this other physiology change that might not even be connected to the thing we said we were going to change, okay? Now to support that, there are a number of studies that show that actually we don't have good quality research to support doing a lot of the traditional swallowing therapies that are happening all over the world, okay? And so this is important because we want to show that what we're doing has efficacy. So you might be saying, but my patients are getting better. And you might be a patient who's saying, but I got better. And this is where I say that is smirktastic. Trust and believe. I think that is smirktastic. However, there are some things to remember. BDNF occurs during your period of spontaneous recovery. So if your patient just had an injury, a traumatic brain injury or stroke, there is a period around 3 months or so where your brain is going to try to improve itself because it has more BDNF. The other thing that's important is when you're motivated during therapy, you're more likely to get better. And so patients who are motivated to eat and are engaged or involved are also engaging more of the important neuroplastic changes, right? So the other thing to remember is better itself is subjective. Are you saying you're coughing less? Are you saying your diet changed? Are you saying that you feel that you're gaining weight? Or are you saying your physiology actually got better and that's what's responsible for those things? I'm not downing those changes. I'm just saying the concept of better is supposed to be more than just some anecdotal suggestions. It's really supposed to point to good research evidence to support swallowing therapy. So to this myth, I say, get the Smurf out of here, all right? Number 2, diet recommendations should be based on food texture before chewing. Okay, so some of us have heard of IDSI, the International Dysphagia Diet Standardization Initiative. And as you can see, these inverted pyramids describe the various textures from thin liquids, such as water, all the way to something like a piece of steak for regular. What's important here is that transitional foods are listed as things that are going to change once your oral cavity, aka your food processor, does what it's supposed to do to make the transition happen. And I'd also like to point out that most daily nutrition is in this transitional category. The issue is that IDSI emphasizes pre-intake over post-mastication. So if you go on Facebook or whatever group, medical SLP forum, there's all these fights about, is ice cream thin liquid? What about oatmeal? And what about, and it's like, or my patient really loves grapes. What is it? You know, we need to think about this because pre-intake emphasis ignores the transition. If we're looking at what's in the plate before it's the food processor, the oral cavity does its job, it's kind of moot, right? And in fact, I'd say, why do we have an oral cavity if we're just going to ignore it? The oral preparation prepares the brain with sensory updates about the properties of the bolus, so an appropriate pharyngeal response is planned. So it has an important sensory component that's happening in the oral cavity, in addition to that it prepares the food to achieve the swallowing threshold, which is when we tell our brain, or the brain realizes that this food is now swallowable. If I gave you a whole strawberry, your brain would be like, absolutely not, we're not doing anything with that, that will kill us. But then you start to chew that strawberry and there's a point where your brain goes, aha, thank you for that information. That is now a swallowable bolus. You have reached the swallowing threshold and you may be swallowed. So what I'm saying is the oral cavity is the place where transitions happen, similar to Clark Kent going to Superman. And if you're up on the more recent Apple TV situations, it's where Mark makes his transition as well. So if you think of the oral cavity as a phone booth and or an elevator, then you understand how important it is. You can't ever say that I haven't given my all to this field because I took some time to chew up some food and spit it out on a board for you guys, okay? Because I know my chewing situation is a good one right now. So for that reason, you can see the difference here. So if I try to cut through almonds before they're chewed, it's not possible. But what you can see here is that I have the capacity to cut through these pretty easily. Now, cooked sweet potato is not terribly different once you chew it, but something like a grape certainly is, okay? These are not the same textures anymore, and that's actually what we're supposed to be analyzing. I know that you're like, as an SLP, I'm already in people's mouths, cleaning and pulling out old mucus, but trust and believe. This is actually what they're swallowing, right? We know that different foods require different manipulation to make them swallowable, and that some require more manipulation than others. So the swallowing threshold is a sensory experience where the oral cavity tells the brain the food is safe to swallow. It is really an important process. When the bolus has adequate cohesion, moistness, and particle size is small enough, when those three criteria are achieved, that is when we say, all right, you can go from the oral cavity to the pharyngeal cavity. and that swallow initiation is triggered more easily. So people with delays, we don't know if it's because they haven't reached their swallowing threshold and more needs to happen to the bolus. And the other thing is that the swallow then should be coordinated to be appropriate for that bolus type because of all the time and information during that transition that the oral cavity gave the brain. We also know that fully dentate older adults required more chewing cycles, longer chewing duration, slower chewing rate, and greater muscle activity before they could comfortably swallow a carrot compared to fully dentate younger adults. This shows that reduced mastication efficiency is associated with healthy aging fully dentate adults. We know that females were observed to have significantly more mastication cycles and longer mastication durations compared to males because their oral cavity is smaller, and that older adults on a dysphagia diet required significantly more masticatory time than older adults in a normal diet group. One of the studies, which I thought was pretty cool, actually used color changing gum to assess chewing efficiency. And as you can see, the closer it is to green is an indication that they didn't really mix everything up as well as closer it is to red. So our diet recommendations should be based on masticated textures, not on pre-food textures, because this informs us on the effects of motor planning, oral sensation, saliva and dry mouth, impulsivity, cognition, dentition, endurance, and I'm sure you can think of many more things. I also want to make a little point there about excessive and inappropriate chewing. At Swallowing Wellness, we get a number of people who have ARFID, esophageal pain, phobias, fear of choking. And here's an example of a 17-year-old who's been chewing pudding for an extended period of time and just will not swallow it for a good while. Even that second swallow, you can see how long he's going to have some tongue pumping there because he's a little concerned about sending it back. And his oral processing time needs to be evaluated because he's overdoing it. Here he's trying to swallow a pill. You can see how difficult it is for him to get it started because he just is so afraid of choking. And swallows and the pill is nowhere back there. I'd also like to point out my dad, who's 100% edentulous and plowed through these wings that I made him. So if we look at the wings before, my poor dad would probably be even smaller than he is if he was in a skilled nursing facility, because they'd say, you don't have teeth, XYZ, and you may have some dysphagia. Absolutely not. But it's what's after ultimately that matters. So to the myth, diet recommendations should be based on food texture before chewing. Well, that makes no smurfing sense. Number 3. The hyoid opens the UES and inverts the epiglottis. Well, how the smurf is that even possible? Is what I ask, given my grasp of swallowing physiology. Some of these images come from stepcommunity.com, which we already mentioned. So what you're seeing here is the hyoid bone. It's a floating bone, and it lives in a muscular sling. And you can see all of the muscles that contribute to the hyoid position. Here you have the epiglottis in orange. And what's important is that while the hyoid is going up and forward and making that loop, the epiglottis is folding in half and going down to the level of the arytenoids. So in the Swallow Physiology Masterclass, I have these graphics for laryngeal vestibular closure. Here you see the larynx at rest before the swallow, and here it's elevated. And while the position of the tongue before it's at rest is here, once you're swallowing, your tongue moves back and helps to bring the epiglottis to a horizontal position. But the epiglottis needs to continue to invert down to the level of the arytenoids, and that occurs because of the pharyngeal pressures on the epiglottis, okay? And that's really important because it points out that most of the forces that lead to epiglottic inversion are indirectly by other structures. There is, however, a small muscle called the area epiglottis that doesn't have enough contractile force to completely invert it, but it can have some direct muscle involvement in inversion. Now, what does that have to do with the hyoid? Well, first, I'm telling you how the epiglottis primarily inverts. But the hyoid does have a relationship with inversion in that the hyoepiglottic ligament acts as a folding point. So as the hyoid is moving up in this way, the epiglottis is moving that way. The thought is that the ligament helps in terms of it being the folding point where that leaf-like cartilaginous structure bends. Now let's address the UES. Well, first of all, look at where the UES is. It's not even connected to the hyoid. It's connected to the cricoid cartilage, and the primary muscle of the UES is the cricopharyngeus. And I'll show that to you here. So we have the thyropharyngeus, cricopharyngeus, and part of the esophagus right here, and together they comprise the UES. So essentially, the cricopharyngeus is the primary muscle of the UES. So that means that when there's laryngeal elevation, it contributes. So where did this whole idea come from? I believe it came from a misinterpretation of Peter Kurillis's paper from 1992. I know I sound so brainy smart right now. And this paper used concurrent video fluoroscopic manometric studies. Manometry is looking at pressure in the pharynx and the UES, and they could look at hyolaryngeal elevation alongside pressure changes. And they did this in healthy volunteers who swallowed 1 ml of thin liquid barium, 10 ml of thin liquid barium, 1 ml of thin liquid barium with the Mendelssohn maneuver, and 10 ml of thin liquid barium with the Mendelssohn maneuver. This is the Mendelssohn maneuver. This is when you swallow and prolong hyolaryngeal elevation, like so. And here are the results. What you're seeing here are time in seconds on the x-axis, and these are the 1 ml swallows with and without the Mendelssohn. You can see that this is the time in seconds that the UES was open in the posterior and anterior direction. Same thing here, except 10 ml with and without the Mendelssohn. And you can see it's prolonged and a prolonged opening. The bolus is bigger and they're prolonging elevation of the hyoid and larynx. So why is this a concern? Well, they find the same trends with the hyoid and larynx. These are the hyoid and larynx trajectories that are prolonged with a larger bolus and with the Mendelssohn maneuver. But the problem here is what they did is people assumed that this correlation meant causation. And the truth is, studies have shown over and over again that if you have a larger volume, almost everything is prolonged in duration. But it doesn't mean that that prolongation is actually because of causation relationship. Sometimes it's correlation, okay? In fact, look at this person. I'm gonna let you watch this swallow. There's epiglottic inversion and UES opening that's pretty adequate. They're gonna double swallow here, clear what's in the vallecula, and everything's fine. This person had the hyoid bone surgically resected because of head and neck cancer. And so clearly, the epiglottis and UES are adequate. So I strongly recommend some kind of hands-on course or some kind of online course. We have them at Swallowing Wellness where you can get fluent in physiology, but I'm also planning something that's a little bit more cost effective, because if we don't get fluent in physiology, we're going to end up in a situation where we are making decisions for patients that aren't best for them. Now let's go to number four, but I just want to say that regarding this, physiology makes me Smurfy. Smurfy means happy if you're not a Smurf fan, because it helps me to sift through some of these misunderstandings in the literature. Number 4, a diagnosis of aspiration pneumonia means aspiration caused pneumonia. If you guys were able to join the STEP symposium from 2020, we had about 850 people join. And what happened is we had a section there where we talked with Ed Bice. And he and I had a talk where we called exasperating. And the question is, how much does aspiration even matter? That's the question we're asking. So here's part of the talk. It's on STEP, but I'm going to give you the important parts here. First thing to know is pneumonia is common. About 450 million people a year have it. And it can be acquired in addition to aspiration through community-acquired pneumonia, hospital-acquired pneumonia, and ventilator-acquired pneumonia. So why are Ed and I frustrated? Like, why are we crying over this issue? Well, first of all, the literature has gone over this quite a bit in the medical world, not just speech pathology, but other areas. This is topics in pulmonary medicine. And the topic here is aspiration, an ambiguous term used for a diagnosis of uncertainty. This is in the New England Journal of Medicine. It's about aspiration pneumonia, and it points out that there's no uniform definition. Here we have another paper in Dysphagia by Susan Langmore. This paper is very important, and it's about predictors of aspiration pneumonia. How important is dysphagia? And it's the issue that all pneumonia is because something was drawn into the lungs, not necessarily because it was swallowed in that direction. And finally, another paper in Journal of Critical Care saying aspiration pneumonia has no gold standard test to really differentiate it very well from others. So what are the facts? The challenge of specifically diagnosing aspiration pneumonia is that the events in the days leading up to the presentation of fever, cough, and chest radiograph infiltrate are unclear. So observing aspiration during imaging does not predict pneumonia because there's some time after aspiration, a few days or so, where some of these symptoms happen, and we don't know if it was because of what they had a few days ago to eat, or if it's because they've acquired it through other means like a virus. Also, aspiration pneumonia, we think, represents about 5 to 15% of pneumonias in the hospital population. Now, mind you, we just said we don't really know how to diagnose it, but according to this study, it's not necessarily clear. Another important thing for folks in the United States is that the ICD-9 code for aspiration suggests an increased incidence. However, it's important to know that this code pays more than the community acquired code. So it could be falsely inflated because if you don't know which pneumonia it is, you might select aspiration pneumonia because it pays more than community acquired pneumonia. And so because of the ambiguity and lack of uniform testing, many in the medical community have suggested abandoning the term. I don't know where the world is on that, but that's just been described in some of the papers. So overall, there's no direct link observed between aspiration and pneumonia for us to be able to say with certainty that if somebody with dysphagia has pneumonia, that it's because of aspiration. And many SLP studies claim a link, although studies do not support it. So what do we need to know? The primary consequence, the pulmonary consequences depend on the volume and contents, bacterial load, and the host's ability to defend against these, okay? The host is more important than the aspiration event alone, meaning these are factors that can make you more likely to end up with pneumonia from an aspiration event, not the event itself, because healthy people don't develop aspiration pneumonia, even though we aspirate reasonably regularly, right? Sedation is a factor, central nervous system issues, frailty. Do you have a compromised immune system? Poor mucociliary transport, decreased physical activity, malnutrition and dehydration, and poor oral health are all factors. So we're not medically trained as speech pathologists. Unfortunately, I call it gaspiration because SLPs are always like, if there's aspiration. So sometimes we overstate, so we tend to be risk averse. For some speech pathologists in the medical space and researchers, we like to say, I'm important. Aspiration is a thing I can help with. And sometimes it's tough to admit when we cannot do things after we told everybody we could do them. And that's just a real human nature factor. So for this myth, a diagnosis of aspiration pneumonia means aspiration caused pneumonia. The truth is, looking in the mirror can feel like a real smurf in the gut. And unfortunately, while it's difficult to do, I think it will really help our patients if we do it and understand that we don't always know if aspiration is even going to lead to a big problem. I'd like to talk about number 5 now, and this is the idea that SLPs are the foremost trained in swallowing. According to American Speech Language Hearing Association scope of practice, they state that speech language pathologists' main goal in service delivery is to optimize an individual's ability to communicate and swallow, thereby improving quality of life. SLPs are autonomous professionals who are experts at screening individuals with possible feeding and swallowing disorders. SLPs have the requisite knowledge and skills to treat these disorders, and SLPs utilize advanced instrumentation and technologies in the evaluation, management, and care of individuals with feeding and swallowing disorders. Now, the question is, are SLPs perfectly poised to manage dysphagia? What does the literature say? Well, one thing is I want to point out that the percent of caseload that SLPs report for swallowing is high. But unfortunately, it doesn't match the percent of SLP curriculum that's dedicated to them. And in fact, swallowing right now appears to be the only one with an inverse relationship, meaning SLPs are doing it more than they were trained to do it, compared to communication disorders. I'll point to a paper that I was involved in where we had this healthy person, they didn't know this person was healthy, swallow, and we asked the audience of practicing speech pathologists who focus on dysphagia, is this a normal or disordered swallow? And unfortunately, this split is way too big, right? 54% said disordered, 46% said normal. Well, as I said, this is a healthy undergraduate student with no issues with with feeding or swallowing. And yikes is the appropriate response there. And when we asked the same people, did you feel prepared to assess and treat swallowing disorders upon graduation? The answer was no for the most part. Now, I'd also like to point out another paper that I was involved in. It's called A Survey of Clinician Decision-Making when Identifying Swallowing Impairments and Determining Treatment. In this study, we had 3 videos that SLPs could anonymously view. They were rated as easy, moderate, and difficult, and they were supposed to say what the primary swallowing impairment was in each of these. And for the sake of time, I'm not going to try to show them one by one and have you look at them, but ultimately, I'm going to tell you what the results were. Across all people who participated, you can see that moderate and difficult were poorly identified, and easy wasn't so great. So then we said, well, let's just take out the people who have had a dedicated dysphagia class, because the truth is, not everybody who's graduated has. And unfortunately, having taken a dedicated swallowing course does not prepare people for moderate and difficult swallows and barely for the easy. Now, what about people who've been trained in MBS through the MBS IMP? Well, as you can see, it's not much better in the moderate and difficult swallows. And then we said, well, what about people who are board certified swallowing specialists? And again, not much better. This was funded by ASH Foundation, associated with ASHA, and it was published in an SLP journal. So on average, SLPs mislabeled 8 or more swallowing bolus parameters and physiological events as disordered that fell within the normal physiologic range. And so we actually have a lot of work to do, because SLPs spend most of their time managing dysphagia. So education is an important part of this. Now, is it true that SLPs have more dysphagia training than other medical specialties? Yes, they have more training. I can't think of another medical specialty, except for perhaps OT, that has 1 to 2 courses on dysphagia or swallowing. However, the truth is that how much there is to know to be competent, no field is scratching the surface, not just speech pathology. And here's the reason why I believe that's the case. It is not possible for any one specialty to manage dysphagia well, okay? The truth is that swallowing involves such a huge range of issues that we just need to be mindful that it would be very difficult. There would have to be just one field dedicated only to this. And Dr. Shakir actually suggested years ago that we have a field called deglutologists, where it is a huge mix of backgrounds that really focus on swallowing. And the last myth is that patients who aspirate or have significant residue should not eat. So I'm going to share 3 brainstem stroke cases with you, because brainstem stroke tends to be the most difficult to change and the most severe swallows. And I'm going to tell you a case of somebody who came to see us after 2 years after having had his stroke, another case that's 1 year after the stroke, and finally one that's 2 weeks after his stroke. For the patient that was 2 years after his stroke, when they first came to see us, they had their stroke in June 2022. This patient was feeding tube dependent and had not been eating by mouth, and had SLP therapy for 2 years that did not include eating. Now remember the neuroplastic principles that I mentioned before, that we don't have evidence to show that non-swallow tasks or swallow-related things transfer. So at that time, when he had a stroke, the MBS showed moderate to severe swallowing issues, trace aspiration, and he was NPO for that. Then he came to swallowing wellness 2 years later, and this is what his swallows look like. So you can see clearly that he's having a bolus efficiency issue, way more than an airway protection issue. The only time he aspirated was on this swallow, and you can just barely see it. So you can see there's some penetration happening there. It's going in and out, and there's going to be a tiny amount that goes just under right there. That tiny bit was the closest aspiration that he had. I'm talking about teeny tiny amounts, right? And so we agree this would be what someone might call moderate to severe pharyngeal dysphagia, trace aspiration, and we would recommend, however, from us, a personalized eating plan as opposed to not including eating. And of course, a referral to ENT for his UES. So that's what we did in June. fast forward, I just want to point out that what we were targeting was the neuroplastic principle of specificity, which says the nature of the training experience dictates the nature of the plasticity. If you're training on the task people need to get better on, they're more likely to get better on that task. So that's what we targeted, as opposed to transference, which says do these other tasks and it should transfer to the functional tasks we want to change. By August, he had his ENT visit, and you can see his UES is opening even more, which was a good thing. However, after 2 years, and unfortunately feeling a bit depressed, we found that he was not as motivated to do any eating outside of therapy with us. At home, we had this whole plan that he was supposed to be a part of, and he just really didn't want to eat. He just didn't feel like he'd change. So his change has been, his progress has been slow. This is just last month. He's not completely independent of his tube, but he says he's taking more by mouth, and it doesn't look terribly different from the first video, but the point is that he's able to take some more by mouth as opposed to being completely tube dependent and taking nothing by mouth at all. Okay, this will take time. The next patient I'd like to talk to you about is somebody who came to us after 1 year since his brainstem stroke, again feeding tube dependent, and his SLP therapy did not include eating at all. This was one of the first swallows we looked at. This is a nectar swallow. And you'll see he's going to aspirate. And what's important here is that he doesn't feel this at all. Okay. It's just like nothing went down the wrong way. Okay. We knew that we wanted to send him home with a personalized eating plan that gave him time to practice experiencing food again without that aspiration. So he's different from the first person who had trace aspiration. He's got a bit more and doesn't feel it. So we trained him to swallow in a supine position with his head on a small pillow, just to give him a chance to experience swallowing and eating without that bolus jumping into his trachea, which he was able to do for several months. And so we put him on a personalized eating plan, and again, made that ENT recommendation because his UES just was not opening. After a few months practicing at home and had some Botox, you can see quite different in the change here. Importantly, he coughs when he aspirates because he's used to that feeling. He's experiencing the food. He doesn't have all those secretions in his throat blocking the sensation. And he returned to a full oral diet, had his PEG tube removed in 1 year after working with us. And then, and you guys can see this for free on swallowingwellness.com, he came back after 5 years for an event that we had at Swallowing Wellness under our help program. If you go to Swallowing Wellness and click education, go to help, you can watch it all there for free. This is him last year, April, at Swallowing Wellness. And there's no audio here, so you're not missing anything, but I want you to see that he's got more physiologic movement, and he does aspirate. He's got dysphagia, but he's very happy because he's eating a wider range of food. He's maintaining his weight. He even said he might be gaining a little bit too much. And he's never had a pneumonia. He's never had a major choking incident. And you can see how his physiology has changed by actually swallowing. And the last one is the brainstem stroke who came to us 2 weeks after he had two strokes in December of 2024. He called us because he Googled us, because when they discharged him into the community, they told him, find an SLP. He Googled, found Swallowing Wellness, and within a week we brought him in for an MBS, and this is what he looked like. He's trying to get the bolus down because his base of tongue retraction was not very good. So this is the only way he could really get the bolus into his pharynx. It takes him a while to start the swallow, and as you can see, not very much goes through the UES, but he does eventually get some of it out. But then with the much larger boluses, he had much more difficulty. And eventually he would just bring it up because he couldn't quite get it down, and he would start choking, in his words. Okay, so we put him on a personalized eating plan, and again, did the same thing, referral to ENT for that UES. This is him 2 months later after doing personalized eating plan at Swallowing Wellness. He didn't even get around to the ENT visit because he had scheduled the ENT visit and they needed to reschedule him. So he ended up not having the visit, and we ended up telling him, I don't think you need it anymore, because eating alone has been very helpful in his case. Mind you, he was still in a period of spontaneous recovery where his BDNF was high. And we took advantage of that by training him on the things he needs to eat to get better. He even specifically said, look, I'm scared to have pills at home. And he was like, if I'm going to have pills, I'm going to have them with you guys, including the biggest pill we could test because of some of his supplements. And, you know, it scared us at first for a second there, but he ended up pushing it down. And so he seems to be doing very well. So those are the 6 myths I have for you. And while I recognize that some of that stuff is heavy, and maybe you're going to have to kick me out of village 6 times. 6 times I get kicked out of the village, 1 for each myth. I'm still very happy to have been here, and thank you so much for listening, and I'll be happy to take some questions.
Thank you, Dr. Humbert. I really appreciate that. We have some questions coming in here. I'll just start at the beginning. Somebody had a question asking about manometry and if this is an effective tool for assessment and can it actually help determine treatment plans?
So my understanding about manometry is that it might not be quite ready for SLP clinical use. I know I hear a lot about its use in GI, but right now for swallowing for speech pathologists, I'm not sure that that the products and the training are ready for clinical use. And the reason I say that is because we wanted to incorporate manometry into one of our trainings, our Swallow 360 training, where we do fees and MBS. And we asked the manometry folks to come as well. And unfortunately, they seem to be like they're not quite ready to do that. So that's my current thought. There may be somebody who knows more.
Excellent, thank you. This next question came in when you were talking about your father in the oral stage of eating, asking about, especially in older adults, when there's oral delays, how do you tease apart whether it's related to physiological differences or cognitive factors?
Well, that's a good question. So with cognitive factors, you're going to have to do what SLPs do and ask questions and give very directed tasks to see whether or not they can actually accomplish them. If somebody has cognitive factors around chewing, they may have cognitive factors around other issues that might actually transition or be applied to chewing as well. If somebody just has difficulty chewing, and they don't have cognitive factors, they probably don't have cognitive factors in anything else. And the reason I say that is I'd be surprised if somebody only has cognitive factors when it comes to chewing and everything else is fine. So if you're trying to tease that out, typically it's a question of whether they have underlying cognitive factors, and when you give them easy directions, they're unable to follow them, especially in severe cases where they don't even know what to do with food anymore, like in Alzheimer's, where they might just have it pocketing for a while. But if you give them directions on how to chew and they're trying to do it, but they're unable to, and they can follow your directions, you might be on the way to believe that it's really a mechanistic, a sensory motor issue.
Thank you. And then when you were speaking about the hyoid bone and its role in swallowing and epiglottic inversion, there's a question here about, is the hyoid bone all that involved in swallow functioning? Should we be working on exercises that target movement?
Well, here's the thing. It's a great question. I'm so glad you asked that question so I can nerd out really hard. So with regard to the hyoid bone, it has a very important role in swallowing. What the example of the hyoid being excised cleanly, that was done with surgical precision, right? And they probably anchored those muscles to something else so they'd be able to contract and actually create a swallow that's functional. But if your brain somehow decides that your hyoid's not going to work, it's because a lot of muscles aren't working. And so it's not that the hyoid's not important, it's that the hyoid is easy to spot. And so research has latched on to the thing that's easy to identify because on X-ray, it's the only bone that's really moving, right? And so what researchers have done is sort of misled, not intentionally, the community by saying, this is a thing we can measure, this is a thing we can measure. We can measure the bolus and the hyoid. So we'll measure them both and make correlations between the two, without considering all the muscles that we can't see that we have to extrapolate to. So research has been challenged, and I believe that the research community is getting better and better at saying we can't be making these connections where they're not there. So with regard to your clinical question, I would focus on the overall function of the swallow, the two main goals, airway protection and bolus efficiency. And if you understand the major factors that contribute to both, you would never be hung up on the hyoid bone, because the hyoid bone is a contributor to a larger function, which is laryngeal vestibule closure. And if you understand laryngeal vestibule closure, then you'll be focusing on the elevation of the hyoid to get it closer to the base of the tongue, so the tongue can move the epiglottis down, the pharynx, as well as stretching open the UES. You would focus on those major factors and not get caught up in the hyoid bone. Because the truth is, studies actually show that a clinician's capacity to accurately judge inadequate hyolaryngeal movement, either by palpation or looking at MBS, is not as good as the actual true metrics that researchers make, which means clinically our judgments are off even if we do really try to look at the hyoid bone. So the answer is focus on the major components that are really very important for airway protection and for UES function, because focusing on the hyoid alone probably won't get you very far.
Thank you. That's good information. There's a few questions here. I'm going to try to compile them into one. Questions about the personalized eating plans and how do you come up with that, and how do you set goals, and what are the consistencies, and how do you reassess the eating plans?
All right, that is too complex of a question for me to answer now because they're personalized, right? It's almost like asking about how do you cook a meal so someone will like it? I don't know. You have to talk to them. You have to see what they like, see what their allergies are, their preferences are, what can you cook, what's available. So the reason I can't answer that is because it is way too detailed. But I can tell you this, we take into consideration some major factors. That slide that I had with the circle of images from dentition to respiration, cognition, those are all the major components that we consider first. If somebody cognitively can't follow instructions, probably not a good idea. If somebody has poor dentition, probably not going to go straight to a steak, right? If you're not eating anything at all. If you have significant host issues in terms of respiration, probably not going to do something where you're going to aspirate a whole lot if you have shown that you get repeated pneumonias. Do you have good oral care? And then after that, after all of that, the next question is, how well are they swallowing? What can we focus on for success? What are the boluses we can start with, and how far can we push? And also, what are their wants and wishes? We've had patients who are like, you know what? I've made peace with the fact that I'm not going to swallow a wide range of foods. I'm okay with that. I can move on. And we're just trying to get them to something that makes them happy.
Thanks. Yeah, we had a ton of questions about that. Thank you for answering that. A question here about what do you consider the time frame for spontaneous recovery for BDNF? When is it at its height, and are they associated?
Well, according to the research, it's immediately after a stroke or after the injury, and then it gradually goes down from there. Generally, people believe within the first 3 months, if you try to do a study where you're showing change, you can't do it because we don't know how much change is happening spontaneously. But importantly, think of it like rebooting your computer, right? Right after you hit that reboot or that start button, there's all kinds of things happening to try to reboot to see if you can work out the kinks. So, and then there's a point where now you're loaded and you're up and you're kind of just stabilized, right? So with regard to BDNF and neuroplasticity, it's generally going to be sooner after the injury. That's when your body's really in recovery mode. And that's why acute care is so important. And the idea that they're having people get up and walk with a ventilator now, because they have shown that this is the time to really take advantage of moving. And it has been shown to be so impactful. Speech pathologists need to be working on ways to get more food in their patients, even if they're just practicing saliva swallows, or just doing secretion management, because that is going to be so much more impactful. We know that they're already more compromised, but being totally afraid of having them eat anything at all might mean that you have given them a lifetime sentence of never eating again. And I know that that's not your intention, but it really does require us to understand the whole system, the whole swallow, and the patient's wants and wishes.
Excellent, thank you. We have a ton of questions, and I know we won't get to all of these, so I'll keep going through them here. 2 questions here about pharyngeal electrical stimulation. Can you explain to somebody what that means and what your thoughts are on that type of treatment?
I don't really have any thoughts on that treatment because it's not really something that I've been spending a lot of time on. I've met Dr. Hamdi in Manchester, and I was around when he was really trying to get it to market. They were at some events recently, and so I don't have a lot of thoughts on whether it's functional. The research is pretty similar in that the exact reason that is changing swallowing, the physiology isn't always very clear. Sometimes it's, well, the aspiration changed, but we're like, but is it because of your device, or what's happening? And maybe it has more of a diffuse effect, sort of like hydration has a diffuse effect on the body if you're dehydrated. It's not quite clear to me what exactly its function is, but I hope it's promising.
Going back to your slides where you were showing how different levels of SLPs, their training levels, and how they score MBS studies, do you see similar levels of inadequacies in other fields? So for example, if you're a radiologist and you're looking at imaging, do you see those mislabelings or misjudgments of those types of images compared to how SLPs are performing in rating swallow studies?
Sorry, you're asking if I'm seeing differences in speech pathologists and radiologists, or?
I think this is the ASH Foundation study showing the percentages of SLPs that are, board certified versus, years in that. Do other fields have similar performance ratings, I guess would be the way to phrase that question, where they're not, seeing
in swallowing specifically? I don't know that. I don't know that that's
just in general.
In general, I don't know if other fields have done that, but perhaps I think that there may have been some studies in nurses. I just don't know if it was MBS. I know that there are studies about surveys about performance and opinions and clinical decision making in swallowing across fields beyond just speech pathology. I just don't know if they were interpreting MBS specifically. And I don't know why we would have another field do that, as much as radiologists might be more important because they do write notes about what they saw, and they kind of just like aspiration yes or no, penetration yes or no. So they might be a group that such a study would be important in.
We have a few questions, thank you for that. A few questions here about your dysphagia treatment recommendations. Are you providing exercises? Are you doing only bolus-driven therapies? How do you put together your treatment plans?
Well, we have done exercises before where one or two patients who are just really, really too compromised to start. We have started just with secretion management with some people. We're just managing your saliva, keeping a clean mouth, and that kind of stuff has just been their main issue because they have so much phlegm that a tiny little bolus that we might introduce would just get caught in all these spider webs in their neck. So we have started people out that way, but it still involved expectoration and functional tasks, involves swallowing. We do very few traditional swallowing exercises. And mind you, we have an outpatient population, and some of them can be more severe, like you've seen, but we try our best to take advantage of improving the host as much as possible, making sure they have good clearance, they have good secretion management, good oral care. We've even sent some people to the dentist before they come back to us to say, once you go to the dentist and come back, we will be willing to help you to try to eat some food. Our goal really here is to see how many times, how well we can bypass the transference principle, which has not been very well shown to be helpful, and go straight to salience. Just the same way you might try to get somebody to get up and start walking. At some point, they have to start walking. Getting on the treadmill and doing other things are going to be necessary at a certain point. So we don't do a lot of swallowing exercises, partly because one, our patients don't want it. Two, they're not compliant a lot of times or adherent to that. Three, they want to eat food. Their host can handle it. Their body can handle it. And they're more motivated, which then gives them more BDNF to actually keep going through it sometimes. And sometimes they're not motivated.
Thank you. And kind of along that here, there's another question. It says, since tasks that assume transference effect are not yet evidence-based in dysphagia intervention, what is your opinion on using vocal exercises like LSVT or pitch glides for swallowing management, particularly if the focus is on overlapping physiology?
This question comes up a lot. Again, if you have gone and done an MBS and looked at the swallow and said laryngeal vestibule closure is a problem, so it has to be tied to the larynx because we're talking about pitch glides, right? We're talking about the larynx. And then they maybe have a voice problem too. If you have adequate laryngeal vestibular closure, you have to use your tongue and you have to use your pharynx. And the way that those things work, you only get laryngeal vestibular closure in a swallow. You do not get epiglottic inversion in any other task. So I don't know why we would focus on pitch glides, which are just focused on the arytenoids, which is good. You want the arytenoids to close and you want them to function. But truly, if the epiglottis is inverted, the arytenoids shouldn't have to be doing too much work. Now, if you're saying that there's poor epiglottic inversion and there's poor arytenoid function, why wouldn't you at least do a supraglottic? Why wouldn't you at least do a valsalva? Pitch glides are for phonation, and so that means that there's actually air going through them. That is a totally different function. So I would focus at least on a supraglottic, so they're at least swallowing along with focusing on the arytenoids. At least it's task specific than to just do pitch glides and hope that somehow phonating would make a difference. If that was the case, then we would assume that vocalists and people who scream and talk a lot would have more protection from aspiration if they ended up with a stroke. And there's no evidence to support the idea that people who are professional voice users and have amazing pitch ranges like Mariah Carey are going to be more protected from swallowing disorders.
Thank you. That gives me an idea for an interesting research study, but I'm going to be mindful of your time here, Dr. Humbert. Thank you so much for volunteering to present to our community. We had nearly 1,000 people join tonight's webinar. There were more questions than we have time to get to. I will share those with you, but if you had a question that you would like an answer to, please feel free to send those to the foundation. Our email is info@nfosd.com. I can forward those on to Dr. Humbert. And again, for the ASHA CEUs, I'll be sending out a survey in the next 5 minutes here. It's required to complete that survey in order to get the ASHA CEUs. If you would like a certificate of participation, please fill out that survey and we will send that to you as well. And with that, in the email that I'll send out, I'll have some upcoming events for the foundation if you would like to get involved further. But Dr. Humbert, thank you for joining us. We really appreciate it. And everybody have a great evening or great morning, depending on where you're calling from. Take care, everybody.
Bye-bye.